So I'll not, I promise I'll not leave the session without explaining those abbreviations. I want to start with a clarification. I am not a doctor. So somebody non-clinical, right after lunch, maybe, as our host was saying, skipped the lunch or had a heavy lunch, and right after that, somebody non-clinical talking to an audience of healthcare. I don't know if it was strategy or something else, but I'll try my best to make this more informational. So as I said, I am not from a clinical background. But from where I sit, I see a technology problem that most of us don't talk about, or we don't try to solve. Since morning, we have been talking about what AI can do, how AI can help change our lives. Yes, definitely AI can do quite some things. AI can do remarkable things. In fact, it can detect, it can discover, it can predict, much before a clinician catches something. But the real question is, are we using AI to its full potential? Is technology ready to use it to full potential, or what are the gaps? Probably we'll spend the next few minutes discussing those things. What do you think? Are we using AI to the full potential?
No.
Yeah. Probably the reality, in my view, is that we are only using 10% of it to its full, to the maximum potential. But where is the gap? Is the model strength, or is the algorithm, is the data? I don't think so. The gap is in the model strength or in the algorithms, or it's not even about the data. I think hospitals have enough data. Models are very capable these days, and every other day we are seeing a new model come out, right? But in my view, the problem is this data, whatever hospitals are having, it is trapped in silos, right? So how do we address this problem, right? How do we make sure that the data talks to each other and then deliver seamless AI in patient care, right? So we'll talk with a few basics. So as our host was asking, probably I'll explain it to him later about these abbreviations. So PACS, it's the lifeline for radiologists. That's where radiologist spends most of their time. And most of the AI is also deployed in this layer as of today. There are numerous solutions which will read the scans, which will give the outcome and all that. And this is where all the imaging lies, the X-rays, MRIs, and CT scans. And then we have RIS, which is Radiology Information System. This is where the why of the scan lives, right? Why the scan was ordered, who ordered the scan, and what scan was ordered, and all that. And in some cases, it is HIS as well, right? And then we have EMR. That's where the entire patient details live. The past history, the diagnosis, the past medications, allergies, and everything, right? So all the hospitals run with these three systems. But the challenge is, as we talked in the beginning, these systems barely talk to each other. That's where the challenge is. And what happens if they don't talk to each other? So as I said, today most of the AI is deployed in PACS, where the imaging is there and imaging is read. The challenge with that is, without integration, without all these systems talking to each other, the image is fed to the AI and you get an outcome. But the context of why this scan was ordered, or what is the past history of the patient and the current medications, everything is missing here. While we still get an outcome, in my view, it is an AI-assisted guessing. It's not AI care, right? So what happens with integration? We give the entire patient context along with the image. That's when there's a clinical reason for the scan is available for AI to decipher more information. The patient's full medical history is available. Current medications are available. And prior treatments and outcomes are also available. So that's when we move from a AI-assisted guessing to AI-assisted care, right? Now, yeah, we know that these are three systems. We also know that they don't talk to each other. But why the integrations have failed? Let's spend a few minutes on the integrations and why they have failed. If you see from a technology angle, all these products that we spoke now, PACS, HIS, or RIS, on EMR, they're all delivered by or developed by various vendors. And their focus was only on the product, right? Their focus was like adding more features or adding more layers to the product, but the integrations were never thought through. It was like more like on need basis the integrations were done. It was always an afterthought. So that's probably one reason why these systems don't talk to each other. Second is the data format fragmentation. Yeah, I agree that there are standards that exist, but I think all these products, they speak a different dialect. That's where the challenge is. Third and most important, the ownership. Each product is owned by different teams. EMR is owned by IT. Now, who owns the intersection? Who has to build the integration? Right? That's the challenge. That's one of the challenges. And last one, speed. I'm sure all of you will agree. The attention span is coming down. Nobody has patience to wait more than 2 to 3 seconds. So if we do all this, and if the AI outcome is taking more than 30 seconds, 40 seconds, I think people will just ignore and they move on. Right? So these are the challenges. Now, how do we solve this problem? That's where I propose a unified intelligence architecture which talks to all these systems. The three core principles that I think should be part of this unified intelligence is context injection, federated inference, and closed loop feedback. Maybe these are tech heavy words, but we'll spend a couple of minutes on what this means in real time. First, context injection. That's what the core problem is. We have been talking for the last few minutes. All three systems, there are different data sets, different context, different information. So this is where we build the context injection layer, where we give the full context to AI, entire patient history, the scan history, the imaging, and everything. So the moment a study arrives, the system should automatically pull the clinical indication from RIS, relevant prior scans, and key EMR signals, and this all should be packaged along with the image to the AI. I think that's one fundamental principle that we all have to keep in mind when we build AI into any of the clinical workflows. Context, the full context should be given to AI. Next one, in my view, is federated inference, and in my view, this is crucial, so that even smaller hospitals and smaller healthcare systems can adopt the solution. So typically, when we build such solutions, we tend to build a central data layer, and we try to apply AI on that central data layer. But what would be more beneficial would be moving the AI to the data layer rather than moving the data to AI. So what I mean by that, we have to run AI on each of these systems independently. So run AI on PACS, you get the outcome. Run AI on EMR, you get the outcome. And you run AI on RIS, you get the outcome. So take these outcomes, run AI on that, so that you get an entire context and the right output from the AI. So that way, the smaller hospitals, it will not be an overkill to build a central data layer. Right? The next one, closed loop feedback. I think this is where most systems fail. It is like we book a hotel, or we order food, or we go to a movie. Everything is fine. Yes, nobody cares. We move on. But something goes wrong. Highly likely that we leave a review, or we try to avoid that next time. Same happens here if there's no closed loop feedback. If clinicians, when they override an AI decision, if they don't give the feedback that why they are overriding and whether they are overriding or not, there's no way the system will learn and improve. So over a period of time, this whole thing becomes stale, and highly likely that they move on and they just bypass this AI decision and go back to the old ways. So that's when I think the closed loop feedback is important. And it is important from technology angle that we implement this in a very intuitive way, in a seamless way, so that this step is never missed. Now, we have seen the three principles. Now let's see with a couple of use cases on, or a couple of, if we apply this to real world, how this looks like. Same, if we go back to our without integration story, typically we send the scan, AI will give an outcome by analyzing the image. Let's say the result is like a low risk and follow up in 12 months. What is missing in the current world is the patient history. Let's assume the patient was treated for cancer 18 months ago, and patient has been symptomatic for 3 weeks. Now, if this context is missing, the outcome is low risk. Now, imagine if we feed this context to AI along with the image, it will be urgent review. It will move from a low risk to an urgent review. That's where I think the context plays an important role in seamless AI delivery. So I see this as an integration failure. It's not an AI failure. So I think that's where we have to focus on. Now imagine the same hospital with this framework implemented. So somebody orders a scan, alongside the information is pulled from HIS, RIS or EMR before even the images arrive. And then this is packaged along with the images from PACS. AI sees the full picture and the output is delivered to the clinician. Now if this workflow is implemented, from a radiologist angle, they have not done anything new. They just did their workflow. AI is doing in the background. The integration is taking over and giving the better outcome. So what is it for us, right? I think we have a diverse group of people here, healthcare, technologists, startups, right? There's a different message for each of us. For clinicians, I would say I think the systems around us, they already hold enough information. But I think the barrier is the wall between these systems. And I think it is for us to break that wall. And for healthcare leaders, it's not about model strength, it's about the depth of integration. Models pretty much, I think, are evolving every day and every model is becoming better than the previous one. But the depth of integration is where the real moat is. And for startups, that orchestration layer and middleware problem, I think that's where the real opportunity is. If we can solve that, I think we can deliver seamless AI in clinical workflows. Now, how do we do it? I would say this is a three-layer approach. We connect. So we connect our systems first. We wire the patient IDs. We identify one problem where we think AI context matters most. And then we orchestrate. So we build a context injection layer. We build a federated inference. And then we measure whether giving the full context is actually changing the outcome, whether that matters or not. And once we understand that it matters, we try to go to the feedback loop. We capture the clinician overrides and then improve the system. I think this is the framework that if we can follow, the systems will be more intelligent and they become self-reliant and self-learning, and that will impact the overall patient care. So in my view, I don't think we have an AI problem and we have a connectivity problem. Right? So what we need right now is, the intelligence is there, the data exists, and standards are also in place. But what we need is a unified intelligence architecture which can deliver this seamless AI. That's all from my side. Thank you.
Thank you. It's a very nice presentation, very simplified and then understandable for anyone.
Thank you.
Actually speaking. And in this, actually, individualized healthcare setups, they do have their own interconnections and setting. Suppose if I have visited this hospital today and I am going to visit another center somewhere else, the next thing, how the things are going to be?
So that's where I think the government policy in terms of ABHA or ABDM, Ayushman Bharat Digital Mission, once the hospitals start adopting that, so it becomes a interoperability, the data becomes interoperable. So wherever you go, everybody sees that same data.
Okay, that is one phase. The second thing is, the second side of the coin is, what about the confidentiality?
Confidentiality is non-negotiable. That's why what I propose is, we don't push the data to AI layer, we move the AI towards where data is. So it runs locally so that you don't risk the confidentiality.
Thank you.